Hello everyone, I am Nora and today I will be speaking about the surgical management of patients with Raynaud's phenomenon with connective tissue disorders. So, the what is Raynaud's exactly? It is an inappropriate response to a cold stimulus in the small vessels of the extremities. It is currently of unknown etiology. So it is placed into the categories of primary and secondary. In both of these categories, the location of the Raynaud's is most often seen in the hands and the feet. However, there has also been occurrences in the ears, the tips of the nose, as well as the nipples of patients. Primary Raynaud's, also known as Raynaud's disease, most often affects men and female equally, and it happens in the younger patients for idiopathic reasons. And it is typically not detrimental to their life, and it will go away as they get older. However, secondary Raynaud's, which is also called Raynaud's phenomenon or Raynaud's syndrome, is prevalent more often in women than men, and typically in their 20s to 30s. And these patients will have other medical conditions, specifically autoimmune and Raynaud's conditions. It's most common in patients that have scleroderma, 100% will have Raynaud's, and in the lupus and the Sjogren's patients, 30% will have Raynaud's. Okay, so how do we diagnose Raynaud's? So typically it's based on just a history of the patient. If the patient complains of discoloration in their hands, so Raynaud's will present as three colors that will appear on the hands. So it will be first white due to ischemic reasons. Second, it will turn blue, and that's due to deoxygenated blood in the hand. And then finally, it will turn red due to now blood reperfusing the area, and that's when the pain is actually felt. So when a patient complains about those types of symptoms, that will make a physician think of Raynaud's. Now, most often physicians will actually try to bring back these symptoms through a cold stimulation test. Another way to diagnose is through the nail fold capillaroscopy, which is a non-invasive, very easy way to look at the capillaries right in the edge of the nail bed. And as you see in this image, in the normal patient, you will see these nice, thin, long capillary beds reaching all the way to the tip of the nail bed. However, with patients with Raynaud's, you'll see these dilated vessels. They don't all reach to the same height, so there will be regions of avascularity as well as microhemorrhages. Another important reason for using nail capillaroscopy is actually helps the physician tell the difference between primary versus secondary. You will not see these in a primary Raynaud's patient, just in a secondary. And it will also, another important positivity is that you will see these changes very early on in the start of Raynaud's. Final way to diagnose that's often used is through MR angiography. Okay, so I wanted to place the Raynaud's onto a severity scale. We have the painless discoloration, folks, who just, observe the three colors that I previously mentioned in cold situations or very stressful situations. These patients can typically just be managed with lifestyle modifications. This will include wearing more layers outside in the cold. This will include moving to warmer areas during the cold months or decrease in smoking. Then we have a little bit severe group, and these will be the patients that have pain as well as the discoloration, and these can be managed through pharmacology. The most commonly used first-line medication is going to be calcium channel blockers, specifically the extended release medications, the dihydropyridine, so the amlodipine and the nifedipine. Next, they'll add on a baby aspirin, and if those two fail, then they'll most often try a PDE5 inhibitor. Now the final group, which is where I'm going to be placing most of my focus during this presentation, are the ones that have failed the pharmacology management, who continue to have extreme pain, ulcerations on their fingertips, and often lead to necrosis and gangrene of their fingers. And these are the patients where we need to take the next step past pharmacology and move into the surgical options. Some of the words I'm going to be mentioning during this presentation that I want to put out there now are sympathectomy. So that's one of the surgical procedures. That's when they remove the nerves from around the blood vessel. You'll also see removal of adventitia. So that's the layers of tissue. There's typically 2 layers that surround a blood vessel. Those will be also released. And then finally, you'll hear the word grafting. First paper I looked at, Management of Acute and Chronic Vascular Conditions, published in 2014. This group's main goal was to analyze the surgical outcomes from the years, I believe, 2000 to 2013 of patients with severe Raynaud's phenomenon. There were specifically 33 patients, of which 78 digits. There are patients that had been sent from a rheumatology clinician or a primary care physician due to ischemic pain and non-healing ulcers that these patients continued experiencing even after being given pharmacologic medications. The interventions that were done were sympathectomies on all patients, as well as adventitial removal, and then during the procedure, based on how the surgeon felt about the blood supply after these 2 treatments were done, they would then either do a graft or not do a graft. And then the comparison that was done in this paper was post-procedure compared to pre-procedure of pain and ulceration status. The findings from this study showed that there was all 33 patients had disappearance of their ulcers. Specifically, 8 patients needed the bypass, and 7 patients also needed additional debridement of the necrotic tissue on their fingers to push for the healing of these ulcers. So the conclusions from this study was that performing this surgical procedure was very beneficial, and that surgeons should have a very low threshold for when they decide to do a vein graft during the procedure. No amputations were completed during that procedure, or no amputations were required post-procedure. I had a few concerns with the paper though. It was interesting that the patients that were sent to this office were ones that had ongoing pain and ongoing ulcerations. However, there was no results provided of the pain level post-surgical procedure. There was one line in the discussion that had mentioned that pain relief was experienced by patients, but it wasn't classified and it wasn't provided as results. The other thing that was concerning to me was the timeline for improvement. So as I mentioned, they had said that all 33 patients had their ulcers gone. But when were these results found? Was this just immediate? Was this just a few days after the surgical treatment? Was this weeks, months, years later? Did they continue following these patients? So this was not mentioned in the article. Next thing was, I'm not too familiar with vascular procedures, but to me, it seemed like that's a little bit of subjectivity is going on during the surgical procedure if the surgeon, decides based on the blood supply they are seeing whether a bypass is needed or not. So I thought that the paper could have improved on the objective elements. And then finally, the location of the bypass was not mentioned in the study. So based on what I saw from this study and the fact that only 33 patients had been used, I thought it would be a good idea to move on to read about another publication to see if I could get a little bit more information and better understanding of when and who a surgical procedure is most beneficial on. So this allowed me to find a second article, which was the classification of Raynaud's disease based on angiographic features. This was published in 2011. And these researchers, their main goal was to develop this classification that would then allow them to decide what type of surgical procedure they wanted to perform on these Raynaud's patients. Similar to the last paper, The patient population were ones that were sent due to ongoing pain and ulceration, the ones that had failed the pharmacology. The intervention that was completed was the sympathectomy and vein or arterial graft or a balloon angioplasty. And once again, they were compared to pre-surgical pain and ulcer status. Now for the outcome, the way that they did this procedure was by completing an MRA on the hands and the wrists of all patients prior to surgical intervention. They divide them into 5 different categories, or 6 different categories, as you can see in these imaging. And the categories were based on what was going on with the radial and ulnar arteries, what was going on with the distal arteries, and based on that, they either always performed a sympathectomy, but they either performed additionally a graft or a balloon angioplasty. And what you can see, so you can see these represented in the titles of the images. And what you can see from these results is that in every single subgroup, there was at least a 50% improvement that they found. So the percentage relates to the treatment outcome, if there was improvement or no improvement, and at least 50% had improvement. So with this study, I had some similar concerns as I had with the previous paper. And first one I want to mention is, so I actually copied and pasted this from the paper itself. This was their results chart, was the treatment outcome. So they never defined what treatment outcome is. They just had improved or no response. And as I had mentioned, this was the paper that had either pain or ongoing ulceration. So which one improved? Did both need to improve to be considered in the improved category, one or the other? It wasn't clear from the paper. Second thing is the timeline for the treatment. Just like in the last paper, when were these outcomes collected and how were they collected? Were they based on what the patient had said? Were they based on like actual type of imaging analysis? What was the timeline for that and how was it collected? And then finally, I thought that since they had this very novel idea of developing these different classification groups, why had it been that they didn't, within those classification groups, they hadn't tried different interventions? Why did they treat the patients within those classification groups with the same type of intervention? Why didn't they vary it so they could see what was most beneficial? So the final take-home messages I want to provide is, why is this important? So the incidence, according to Cleveland Clinic, is about 3 to 5% of the population is affected by Raynaud's. That's not specifically saying that they all are severe Raynaud's patients, but that there's a significant percentage of people that are affected, and of that, there are quite a few severe patients. Second point is the importance in understanding primary versus secondary, Raynaud's disease versus Raynaud's phenomenon. Those are 2 different categories. We focus on Raynaud's phenomenon in this presentation. And then finally, both papers show that there is improvement with surgical outcome. However, it is unclear still with these papers when surgical outcomes should be done, what type of surgical outcome, and how we should decide what patient should receive what. And for this, we need to do more studies and we need to have more objectivity within the studies. So up to date, there are no additional studies. These are pretty much all we have, and these are what we need to rely on, and hopefully people will take charge and start looking at these questions. Thank you.